In the slides, we're going to be talking about airway equipment and the different uses for it. First piece of equipment here is a wall-mounted suction unit. This device allows us to clear a patient's airway of any secretions, blood, emesis, or other airway obstructions that can be removed via a suction device. Because it is mounted in the ambulance, it is stationary and not mobile. There are different portable suction units that allow for us to take that piece of equipment into the patient's home or residence where they are located and utilize the suction equipment there. The next piece of equipment is a BVM or bag mask valve device. As you can see in the photo here, there are different sizes. Adult, child, and infant BVMs are used to artificially ventilate your patient. This uses positive pressure ventilation by placing the mask over the patient's mouth and nose, and by squeezing the blue bag here, it allows for us to provide ventilation at the appropriate rate and depth. It is important to remember to use the correct size bag when ventilating that particular patient, as using an improper size bag can overinflate the individual's lungs, causing barotrauma. Overinflation can also cause gastric distension. Gastric distension is the buildup of air within the stomach, which will eventually have to escape at some point, often causing emesis and potential aspiration. When utilizing the BVM, there's approximately 500 mLs to 600 or 700 mLs, depending on the individual size, in an adult patient's lungs capacity. The BVM is much larger than that in terms of capacity, and therefore only ventilating to seeing a visual chest rise and fall is necessary. You do not need to completely squeeze the bag in order to see chest rise and fall of a patient. It is even more critical when dealing with pediatrics in not overventilating them, as they do not have the same capacity that an adult does. Next piece of equipment that we carry is an oxygen cylinder or tank. In the photo here, you can see two different sizes of oxygen cylinders and tank. The most common one that you will find on an ambulance is going to be that bottom one, the smaller one. And also next to that is a regulator. Those regulators allow us to provide a appropriate flow rate of oxygen to the patient as necessary based off of their assessment findings. As seen in the previous slide, there are different types of oxygen cylinders. All oxygen cylinders are seamless steel or alloy canisters filled with oxygen under pressure. They will also have that green or green and white painting on them to identify them as an oxygen cylinder. Come in a variety of sizes identified by letter, with the D cell being 350 liters, E being 625, M 3000, G 5300, and H 6900 liters of oxygen. Again, all of these vary in size and shape. However, the most common ones are going to be the smaller D cell cylinders that we carry on the back of our cot or in our jump bags. The oxygen regulator is a very important piece of equipment when working with the cylinders and oxygen equipment. It allows us to connect the bottle and open it up so that we can provide oxygen therapy to our patient. There are different ports on here, but essentially they connect via the large opening on the left-hand side, the pressure regulator, indicating how many psi is available in that body, is in the middle on the gauge, and then the flow meter is that marking on the right-hand side of the regulator with the indication that it is currently flowing 0 liters per minute. Our oxygen therapy tubing is connected to that bottom port on the right-hand side, and then that black arrow in the middle is indicating a high pressure flow meter. This particular regulator allows for high pressure oxygen to be delivered through hoses via the thread connection, but not all regulators have that particular piece of equipment. Majority of these regulators allow for pressure or liters per minute up to 15 liters. However, some go as high as 25 make sure that the device that you are using allows for that flow rate. Otherwise, it will not be effective. There are a number of different pieces of equipment that we utilize for patients with shortness of breath or airway issues and for applying oxygen, one of them being the non-rebreather mask pictured down below. The non-rebreather mask has a standard mask fitting shape to it, and it has a reservoir bag, but it also includes the round discs or the flutter valves that allow air to be exhaled by the patient, but not to be rebreathed back in. This allows for the highest concentration of oxygen possible, roughly 90 to 100% depending on the fit to the patient's face. Oxygen delivered via this particular piece of equipment flows at 10 to 15 liters per minute. It is important to note that with a non-rebreather mask, the reservoir bag needs to be fully inflated prior to applying it to the patient's face. Otherwise, the patient will experience a feeling of suffocating as they are not inspiring enough oxygen. The second piece of equipment that we use for supplementing oxygen is a nasal cannula. The nasal cannula comes in many shapes and sizes and now has different pieces of equipment attached to it. Nasal cannula is attached directly to the oxygen cylinder via the connection port and allows for 2 to 6 liters of supplemental oxygen to be delivered through the nares or the nose. If you are to turn this up, all it's going to do is increase the flow. It does not increase the actual oxygen content to the individual. It is important to know that this particular piece of equipment is useful when dealing with patients with minor shortness of breath or in providing that comfort or two to your patient. When reviewing the airway, we must also talk about the physiology, in particular the upper airway. So at the upper airway, we have our nose, in which air is inspired and flows through the nasal cavity sinus passages. Through there, it follows a track down through the nasal pharyngeal and past the oral pharyngeal area, down through the laryngeal pharynx, past the epiglottis, past the vocal cords, and down into the trachea. Manual manipulation of the airway is sometimes necessary to open the airway appropriately. There are some particular maneuvers that allow for us to open up this airway more effectively. As you learned in BLS, the head tilt chin lift maneuver is the preferred method when trying to open up a patient's airway when they are not responding and not protecting their own airway. However, sometimes in traumatic situations, we must maintain spinal alignment to prevent any injuries to the C-spine. This would require us to perform a jaw thrust maneuver, which, as you can see here, is positioning the airway in an appropriate manner while keeping that spine in the correct alignment. By placing our fingers just at the position of the angle of the jaw, it allows for us to thrust upward, opening up the jaw, moving the tongue out of the airways opening, and providing a open airway maneuver without potential injury to the spine. Another piece of equipment that we utilize to maintain a patient's airway is an airway adjunct. The one pictured here is an oral pharyngeal airway, or OPA. The OPA is inserted into the patient's mouth in an appropriate manner that allows for us to move the tongue out of the obstructing airway. By holding the tongue in the correct position, it provides a secure airway and allows us to no longer have to do a manual manipulation of that patient's airway. The OPA is used for unresponsive patients only. If, while inserting the OPA, the patient begins to gag, stop the procedure and prepare for suctioning. You may also need to help assist with ventilation of your patient at that point in time as well. Once the OPA is inserted, utilize a BVM to ventilate your patient at the appropriate rate and depth. When utilizing an OPA, we must determine the correct size. To determine the size, measure the device from the corner of the mouth to the tip of the earlobe on the same side. Alternatively, measure from the center of the mouth to the angle of the lower jawbone. Do not use the device unless you have measured and verified the size. If the airway used is too big, air will be directed into the stomach instead of the lungs. It can also cause further obstruction of that particular airway. Click on the link below to watch a video of OPA insertion. Pictured below is the way to measure an OPA, utilizing a corner of the patient's mouth to the tip of the earlobe to correctly identify the OPA size necessary to maintain a patient's airway. The second airway adjunct that we have available is a nasopharyngeal airway, or NPA. The NPA is used in patients who have an intact gag reflex and that are semi-conscious. It allows for us to bypass that gag reflex by inserting the soft rubber tube in through the nair and down the back of the nasopharyngeal airway space. As with an OPA, the correct size must be measured out prior to inserting an NPA. As seen in the picture here, you measure from the patient's nair that you are going to be inserting the NPA into to the earlobe. This allows for the correct size in terms of length. NPAs are measured in French, so there are different French sizes based off of that particular size. It is a measurement unit. When inserting the NPA, make sure that you are picking the largest nair to insert into. Typically, this is the right nair. Measure appropriately on that side, and then apply a generous amount of lubrication to the NPA to facilitate insertion into the patient's nair. When inserting in, make sure that you're inserting with the bevel to the septum and that you are sliding it in correctly. When inserting on the right hand side, you can just follow the anatomical alignment of that patient's nasopharyngeal passageway, and you might have to wiggle it as you're inserting it. When inserting on the left, again, make sure that the bevel is to the septum, and this is going to flip your NPA inversely. You will need to rotate the NPA as you're inserting it to follow the anatomical position of that nasal passage. Click on the links below to watch videos on how to insert NPAs. When inserting an NPA, gently push the tip of the nose upward and insert the airway with the bevel side towards the base of the nostril or towards the septum, bevel to the septum, which is the wall that separates the nostrils. Insert the airway, advance until the pharynx rest against the nostril. Positioning of the airway for manual manipulation is incredibly important. In this particular slide, you can see here a couple of different alignments in terms of positioning and how changing that angle helps with that visual alignment when necessary. So you have your oral axis, or OA, you have your pharyngeal axis, and then you have your laryngeal axis. As you can see here, when the patient is lying flat and there is no padding underneath the head or shoulders, you cannot see anything in alignment. When you pad under the head, the pharyngeal and the laryngeal axis align more effectively. However, the OA does not. When you apply that head tilt maneuver, you then allow for better alignment throughout, which when inserting an OPA or an advanced airway, as we'll talk about later, is incredibly important with this particular positioning for alignment. As we saw in the last slide, positioning is incredibly important. As you can see here, depending upon the patient's size and demographic, you might need to adjust how you're positioning your patient and what you have underneath them in order to align those axes as most appropriately. As you can see here, OA, LA, and PA are not in any alignment when the patient is lying on a pillow. However, when lifted up and using what's called a ramp technique, applying pillows underneath the head and then underneath the shoulders as well, almost as if they are sitting on kind of a ramp position here, that incline, the OA and the PA and the LA align a little bit more effectively than in the previous or than in the other side of the picture. When dealing with pediatric patients, it's incredibly important to get that airway alignment correct. Pediatric airway anatomy is very different than adults. They have larger tongues, smaller airway openings, and higher increased chance of airway obstruction when not positioned appropriately. If they are too far forward, their chin is too close to their chest, their airway will be occluded. If you also tilt the head back too far, they can occlude their airway as well. They must reach what's considered a ear to sternal notch alignment here, which is that ear to the sternal notch here based off of the arrow, that small short green arrow down there, is in good alignment. When that is in good alignment, that airway is open and ventilatory status can be effective at that point. As you can see also in this picture here, the child has multiple pads underneath. Not only do you see the blanket down below in the white, but also these towels rolled up underneath the shoulders and the head to allow for a good semi-ramping position here for this patient's airway to be opened effectively. Pediatrics, particularly infants and small children, have a higher potential for airway obstruction and occlusion simply because of position. So make sure that the position is appropriate for those patients when manually opening up the airway. In this slide is pictured an advanced airway called an I-gel. An I-gel is an advanced airway that allows us to secure a patient's airway from potential obstruction or aspiration from blood, emesis, or any other potential secretions. This secures the airway and allows us easier ventilatory status. Click on the link below to watch an insertion video of an I-gel. A second advanced airway that we have available to us is called the King Airway. Unlike the I-gel, the King Airway has a balloon reservoir that allows us to occlude the oropharyngeal airway from any air entering the space. It is also designed to be inserted into the esophagus, and that small balloon at the bottom is designed to occlude the esophageal opening, preventing any emesis, secretions, or gas from coming out of the gastric area. Click on the link below to watch a video on the insertion of a King tube. Finally, the last device that we have available to us, but not often seen, is called the combi tube. The combi tube is a dual lumen advanced airway device that also utilizes balloons to prevent any air or secretions from coming through up from the esophagus. It is designed to be inserted into the esophageal opening. However, it sometimes is placed within the tracheal opening, which is the reason for the dual lumens. Click on the link below to watch a video on combi tube insertion.